So, today we'll do that first part on the exocrine pancreas, gallbladder, liver pathology, and then Monday we'll continue in that chapter. I need to double check on quiz 7. I know for sure it's going to cover gastrointestinal. Oh, okay. Gastrointestinal pathology. I'll see if it gets into the pancreas chapter as well. Is it not connected? Oh, it is not. You are correct. Let's try that again. See if this works. That looks a little bit better. Makes a little bit more sense, perhaps. Yeah, so quiz next week, Tuesday, for sure, is definitely cover all of gastrointestinal pathology. It might cover a little bit of the pancreas. I'll double check on that on Monday so you guys will know for sure whether or not. Questions, scheduling-wise or other? I'm sure you're ready for the weekend after getting out of that exam and ready to rock and roll. Right. Oh, yes?
I was just wondering about the exam next week.
Let me go.
Exactly every summary exam.
Everything since our last exam.
Okay.
Yeah, everything since our last exam, all the way through that kidney pathology. So everything since exam 2. It's a pretty good chunk. Absolutely. Yep. Okay. Any other questions? That's a good one. Any other questions? Okay. Let's go ahead and have a word of prayer, and then we will get started. Father in heaven, this morning we'd ask for clarity of mind as we study some more pathophysiology. Be with each of these students, give them a restful weekend, and give them the strength they need to meet the challenges that are yet ahead. We thank you for this. In Jesus' name, amen. Okay, well, let me open up today's material, and we can talk about the pancreas and some associated pathology there as well. Okay. First off, just a brief reminder on our good friend the pancreas has 2 major functions. It's got the exocrine function, we remember that, secreting the enzymes, the amylase, the lipase, the proteases that are necessary to digest the nutrients that come in your food. It's also got the endocrine function, the very nice islets of Langerhans contain the alpha, beta, delta cells secreting the insulin, glucagon, etc. Okay. First disease we have in here is this annular pancreas, just this malformation. Forms the ring around the duodenum. This makes sense. Do you guys remember anatomically? Remember the duodenum? In some ways, the C shape of the duodenum kind of cradles the uncinate process and head of the pancreas. And then it's not hard to imagine developmentally, this potentially pancreas could wrap all the way around and then kind of choke the duodenum off a little bit. So it wouldn't be able to pass food through there. Any questions on that one? Okay, that's a fairly short point. Acute pancreatitis is a much larger and bigger point here. We've hinted at this before because of the fat necrosis before, so that's kind of nice we come back to it. Any questions? Anything in here? I'll let you guys lead the discussion here. Anything in this area that you might have questions on? I'm trying to think if there's anything that I need to add in particular. I'll cut to some bigger points that I think are important. One jumps out at me at the very bottom of acute pancreatitis. Do you see the DIC and the ARDS down there? Acute respiratory distress syndrome. Do you guys remember the 2 separate ways that we get that? Or what is truly causing that in acute pancreatitis? Why would I have DIC? Why would I have acute respiratory distress syndrome if I've got acute pancreatitis? Close. What would cause the clots in DIC from acute pancreatitis? What's going on here? Well, you remember with a heart attack. I'll just put it that way. With a heart attack, if I have a heart attack, I get CKMB, I get troponin in my bloodstream, right? If I have pancreatitis, what goes into my bloodstream from that damaged pancreas? These nasty enzymes, amylase, lipase, and importantly, proteases. How do I activate my clotting cascade? They're proteases, they're zymogens, and they have to be cleaved in order to be activated. So they'll be abnormally activated by these proteases that are in the bloodstream. I get all those clots. Those microclots then, of course, go with vascular obstruction and all that. But then also I'm going to use up all my clotting factors. Now I've got DIC. Same thing for the respiratory, right? What's the definition? This goes back to respiratory, acute respiratory distress syndrome. What's the fundamental problem there? Damage to the diffusion barrier, which is kind of the alveolar membrane, the endothelial cell side, the space between them. Damage to the diffusion barrier is acute respiratory distress syndrome. These enzymes will chew away at that membrane. Good. Anything else we have here? Questions? I think we'll leave it at that, unless anybody else has any clarification points they'd like to add. Chronic pancreatitis. This is when we got recurrent bouts of pancreatitis, very commonly. Unfortunately, very commonly associated with alcoholism. Cystic fibrosis in kids can block the output, right? Cystic fibrosis, the calcium chloride channels, don't work, and you get really thick secretions, and the thick secretions then block the outflow of the pancreas, and then you get any blockage of a system causes inflammation backstream, right? We talk about appendicitis. We talk about the diverticulitis. Here's another tunnel that you can block off and, not surprisingly, cause inflammation. Okay. One interesting point about the chronic. Did you notice that the pancreatic insufficiency here eventually develops because the pancreas is destroyed over time, and that leads to an interesting diagnostic problem here, and that is, with acute pancreatitis, you go looking in the serum and you go find that amylase, you go find that lipase, because they've got it. Can't find it here. Why can't you find it in these patients with chronic pancreatitis with insufficiency? Literally, the cells are so destroyed they can't even produce the enzymes anymore, and so those enzymes can't get into the bloodstream. That's a good point. Yeah. Could be a very tricky question that some clinician may ask you someday when you're out on your rotations talking about a patient with chronic pancreatitis, why we wouldn't want to be looking for those enzymes, or may not be as helpful to look at those enzymes. Pancreatic cancer, pancreatic carcinoma is another key one in here. I forget my slides, so I'm going to have to look here. I just have activating the enzymes. This might be helpful for this here. Common in the elderly. Some cancers are more common in the elderly versus the young, and it tends to be cancers that are, all cancer requires an accumulation of a certain number of mutations. To accumulate those mutations, it often takes time. Cancer in general is more common in the elderly. There's just actually a few exceptions that happen in kids, where kids are often inherited certain mutations that make it so that they have a less amount of time to get to the full complement of mutations needed to have the cancer. So actually most cancers we can associate with the elderly here. This one is one that just usually never happens in kids, and so we can put it on the elderly. Yeah. That's the best answer I can come up with. I'm not sure if I have a perfect one here. At least not one specific to the pancreas. There's nothing interesting about the pancreas that I know of that would cause it to happen only in the elderly. Obstructive jaundice, we know that could happen, right? A tumor develops right on the output here of the pancreas and the gallbladder, and we could block the outflow of bile. That makes a lot of sense. Oh, there it is. Okay, migratory thrombophlebitis, the Trousseau sign. That is the one. That's I shouldn't be so excited. This is the Armand Trousseau. He was the physician who noticed the migratory thrombophlebitis in his patients, identifying it as a marker for pancreatic cancer, dies of pancreatic cancer and having a migratory thrombophlebitis within just a couple of years after that. Armand Trousseau. Okay. Probably no one in history has been so excited about relaying that story. It's very inappropriate there. Sorry. Apologize there. maybe the last things we'll mention, just a terrible, terrible prognosis for this particular cancer. Very low survival. 1 year survival, less than 10%. Do that math. Ooh, that's a pretty rough one. Yes.
Okay, like chronic pancreatitis can lead to pancreatic carcinoma.
That's right.
Acute can lead to chronic. So
That's
like,
right.
Is there any way that like in those patients, if they show those signs first, like
You could maybe increase screening
Yeah.
and whatnot. You could. You probably could. I would.
This isn't the problem normally that it comes so late that you don't even realize anything's wrong.
That's correct. That it often doesn't present with any early signs. Especially for those patients with chronic pancreatitis, I would actually be surprised if there wasn't practice guidelines that were out there recommending increased screening via ultrasound, if they have serum markers. I'm not sure if they have a really good one, but if they had serum markers, potentially using those. Yeah, you're right. That's exactly right. Another capstone. Go ahead.
Any idea why tobacco causes a high risk of pancreatic cancer?
Yeah, tobacco causes a lot of cancers, and it is the carcinogens that once you've inhaled the smoke, they move into your bloodstream, and then your bloodstream moves throughout your body, and certain cells are more susceptible to those mutagens than others, and or are exposed at higher concentrations. Like we talk about the urinary tract cancers with smoking, because they're at high concentrations because of the concentration of those chemicals into the urine. Here, my guess is that the pancreatic cells must be a little bit more susceptible to those mutagens. Yeah. Yep. Yeah, polycyclic carbon molecules are not good for our cells. Anything else in there that you guys have questions on before we move on to the gallbladder? Yes, Jillian.
Surgery to remove part of the pancreas?
What's that again?
They talk about doing surgery to actually like remove part of the pancreas.
Right.
Live without that, I guess?
You can without part of it. You generally need some. That's a really, really good question here. You can give supplemental enzymes orally to help people digest their food. I don't think, at least I've not heard, that you can completely remove a pancreas and then still be okay. I think you have to leave at least a little tiny bit to survive without para-enteral nutrition. Basically, we have to directly inject it. Yeah.
Kind of going off of that, why during the Whipple procedure did they also get rid of the first part of the duodenum and the gallbladder? I guess that's not where the issue is. Is it just because they're so intertwined there?
Yeah, it could be because they're so intertwined. The pancreatic cancer, by definition, it is invasive. And these are the structures, if we look at our previous image, that are right. If I've got a cancer, and I assume they're probably talking about cancers that are down at this end, you could imagine how close this would be. Now, the gallbladder, I'm not sure if that's really, I don't know. I'm not sure why that would be necessarily a good idea, but maybe there is a good underlying reason behind that. I make sense of the duodenum. Duodenum, yeah, okay. There's pancreatic tissue so close to it that we might not be able to easily dissect away the pancreatic tissue from the duodenal tissue. Let's take the whole thing so we got the whole thing out. Yeah, you'd have to shorten up the intestines and potentially reattach a duct to the intestines and artificially then create a new main pancreatic duct. And yeah. Good. All right. Anything else in this section or anywhere else there you have questions on? Bile structures are all next. This is a nice breakdown image if you want to review it for what causes acute pancreatitis. Oh, yes, the poor guy, Armand Trousseau. There he is. Okay, gallbladder. Here we go. Okay. Biliary atresia, just a failure to form. We talked about aplasia at the very beginning of the semester as one of the examples of the problems with cell development, where we don't get something. Well, this is an example of that sort of cell development there, yeah. Cholelithiasis, so this is a big one, cholelithiasis, gallstones, supersaturation. You guys know what that means, right? Supersaturation. How many in their chemistry class got to make crystals? How many got to make crystals? About 2/3 made crystals, yeah. So what do you do to supersaturate a solution? You get a whole bunch of the solute in there. You can heat it sometimes and then cool it back down. And when you heat it, what's that? Evaporate out the water so it's concentrated. these individuals have this very, very concentrated bile, and essentially anything in the bile could precipitate out. Cholesterol stones are very common. You can end up precipitating out some of the phospholipids. The lecithin can precipitate out, and of course even the dyes, the bile pigments. Bilirubin conjugated version of that can also precipitate out. Very commonly, radiolucent, and you guys know what that term means from your anatomy. It means that we can't see it on a radiograph, right? The black, X-rays pass right through it. And then the risk factors. So estrogen, female gender, obesity, multiple pregnancies, oral contraceptives, all those things can do it. Absolutely. Okay. Oh, yeah, bilirubin stones. There are certain things that can precipitate that, especially when you got really high levels of bilirubin floating around, like maybe extravascular hemolysis. That's a good example. Questions in this area? Yeah.
What's clofibrate?
Where's that one at?
It's a risk factor for the cholesterol stones. It's like after the estrogen.
Yeah, clofibrate. I do not know off the top of my head. I don't know. Do you know?
I think, well, in the video, he said that it was a drug that's used to lower lipid.
Oh, is it maybe a statin? But that wouldn't make sense because that would lower cholesterol levels in the blood. It's HMG coenzyme reductase inhibitor. I don't know, but that helps. So apparently it's a drug that interferes with cholesterol metabolism. Maybe it facilitates this actually could be a mechanism, right? It facilitates the liver to secrete a bunch of cholesterol into the bile, get rid of it out of the body, but then, of course, maybe more likely to have cholesterol stones. I don't know. Anything else in that section? What's the definition of biliary colic? So we know a colicky baby is a fussy baby, right? Yes, I'm very fortunate this one is not fussy at home. It's wonderful. It's a good thing. So you got pain coming from the gallbladder. Pain coming from the gallbladder, absolutely. So right upper quadrant pain is not uncommon. You know something odd about this? We didn't ever talk about this, but there's an odd referred pain from the gallbladder. It can often be on the back, and like the upper right side of the back is sometimes where it can radiate to. It's a referred pain pathway from the gallbladder. We know that acute pancreatitis or obstructive jaundice could occur as a result of having a bile obstruction there. Yeah. Okay. Here's some various stones. These stones here are the bile pigment stones. Jaundice, just some really nice images of jaundice. Two individuals, non-jaundice, and of course jaundice there. And the scleral, what's it, ichthia? What's that? It's ichthia or something like that. I don't. Is it in the book? Maybe it's in the book there somewhere. But it's the sclera turning, of course, yellow along with the rest of the body. Just some more images there. Okay. Let's see. Acute cholecystitis, just the inflammation of the gallbladder wall. Oh, there's the right scapula, by the way. Hey, there it is. Perfect. Even talked about the radiating pain to the right scapula. Not an uncommon referred pathway there. Risk of rupture if untreated, and so the cholecystectomy is the removal of the gallbladder, very commonly done. Okay. And stop me if you have questions. Chronic cholecystitis, this is the one in which we've got a gallbladder that has got chronic inflammation, porcelain gallbladder, late complication. I wonder, do I have an image of it? I don't think I do. Darn. What's the porcelain gallbladder? Yeah, dystrophic calcification. Calcifications show up on a radiograph, and it looks like they've got a bony gallbladder or a calcified gallbladder. So porcelain is kind of white, so they kind of connect that in there. All right. There's a couple more. The ascending cholangitis there. So bacterial infection all the way up into the biliary tree. And then gallstone ileus. So you can have a gallstone actually obstruct the small bowel impressively there. Yeah. Any questions on either of those two? Questions there? Okay, here is an image on the screen that you've seen many times before. This is a great thing to review. The good news is you've had this in phys, and so you should hopefully know your metabolism of the heme group and how it's broken down and its eventual effects, right? Should I go through it quickly once, just as a reminder? Let's do it. Let's go. So we know that heme is part of the hemoglobin. It's the part that actually holds the iron in place. There's 4 of those for every hemoglobin molecule. In the spleen and the liver, there are macrophages that chew up old red blood cells. These red blood cells burst because their membranes get old and they squeeze through tight capillaries, so the macrophages are there to clean up the mess. As the macrophage picks up the heme groups, it changes them. The first change is inside the macrophage, and it changes the heme group from being its reddish color into being biliverdin, which is this greenish color. We see that in bruises. Secondly, again, inside the macrophage, it changes it into bilirubin. Bilirubin here is unconjugated. It means it is water insoluble. And so it is secreted from the macrophage, and it has to bind albumin to be carried through the blood, complex to albumin. It needs a carrier. Albumin is going to deliver it to the liver. The liver picks that up, adds a couple of little sugar molecules on it to conjugate it. Now it is conjugated bilirubin, which is water soluble. That's the version that ends up in our bile. From there, it goes into the gut. The gut has bacteria that begin to digest and break down. The conjugated bilirubin turns into something called urobilinogen. Urobilinogen has 2 paths. One is it can continue on out the digestive tract and turn into stercobilin, which gives feces the brown color, or urobilinogen can be reabsorbed back into the bloodstream, and into the bloodstream it goes and can end up going into the urine, being converted into urobilin, and urobilin is what gives urine its characteristic color. So we can have changes in the color of urine and feces depending on changes in bilirubin breakdown. Questions on that as a reminder. If there's any part of that you're curious about, we can definitely clarify any step there. Yeah, go ahead, Jacob. Yeah.
If someone is jaundice,
Yes.
that is due primarily to unconjugated bilirubin?
No. It can actually come from either conjugated or unconjugated. Both are yellow. And I hope they did that here. Yeah. So if you look here, here's bilirubin unconjugated. Here's bilirubin conjugated. The sugars don't change the color of it. It's still yellow. And so you can end up with either one in your body, and either one causes jaundice. Yes?
Does the bilirubin play a role in digestion at all, or that's just how it's gotten rid of it?
It mostly is just the way that your body gets rid of this molecule. It doesn't necessarily, we've got the fancy bile salts that help us with the fat digestion. We've got cholesterol there to help with fat digestion. These particular molecules, not so much. The liver is a major detoxifying organ, and just like the kidneys, it often will modify molecules in order to get them out of your body, and one of the ways it can do that is secreting them into the bile. So for example, the liver will actually take some drugs, modify them, and throw them into the bile so that you can get them out of your body. As best as I know, that's the closest to what's going on here. It doesn't actually care to use it for a purpose, but it's getting rid of it. Mm-hmm. Yeah. Okay, there's a wonderful, wonderful table, the causes of jaundice, table 11.1. There's a fair amount to know in this section. It gives you good laboratory findings. So UCB is unconjugated bilirubin, CB is conjugated bilirubin, and then it kind of breaks down where what findings you would have with these various diseases. Clinical features, etiology, really good stuff in that chapter there, in that table. There's a little Billy Light. You've probably heard of those. Just a random thing I threw in there. Little babies. We actually saw these. So remember Evan was briefly in the NICU there for a week, and so we'd be walking down the hall, and the whole room would be all blue and lit up, and the little babies got these cute little eye masks on to try to protect their vision from the UV light. and then they're getting a nice little suntan in their little tiny cribs. This was just a random thing I threw on there, and probably many of you already know about these. In this particular section, actually, there's a great video on bilirubin metabolism and liver and jaundice in general on this website there, handwritten tutorials. There's lots of good videos there. I'd recommend checking those out if you haven't already. Any other questions that you guys might have? If you don't, then we will leave it at that, and I will see you guys next week. Have a great weekend.